I guess I'll make my own introduction. My name is Jamie Allman. I'm a neurosurgeon over at Neurosurgery University Hospital. And I'm been a neurosurgeon now for more than, I guess, 26 years, a long period of time. Did my residency even before that. And I invited also Dr. Motivala to come. And Dr. Fontana, unfortunately, is running a little bit late. Hopefully she'll join shortly. But I'm going to see what I can do about getting up the presentation. So
I can also introduce myself while we're waiting. My name is Anuradha. I'm a medical student from Australia, and I was asked to join this session to help moderate the Q&A.
Fantastic. Fantastic. All right, I'm getting up a presentation that Dr. Motivala had actually put together a couple of years ago, which was an excellent presentation. That's why I wanted to give that to you right now. So give me 2 seconds to get it downloaded here. And then I'll work on sharing the document. I'm just going to share my screen. Okay, does everybody see my screen?
Yes, we can see.
Okay, all right. So Dr. Motivala put this together. It's really an excellent presentation. I think it's just sort of basic, great overview about women in neurosurgery and how we are less than a minority, which is interesting. Times are certainly improving for women in neurosurgery because right now approximately 20% of all residents are women. So we really are making a tremendous amount of progress. It's just that when the women are graduating and diffusing into the general neurosurgical population, all those who are board certified, turns out that we're roughly about 8% of all neurosurgeons who are board certified in the United States. So we still have a way to go. And I think that it's incumbent upon all of us to help promote women in their interest in neurosurgery, as well as getting into the field of neurosurgery, and then while they're in neurosurgery, then sort of promote their interest in residency, and then becoming, practicing neurosurgeons when they graduate, and hopefully some going into academic neurosurgery, others going into private practice, and to have all a problem. I just wondered if, Amy, if you're on, or we just need to help Dr. Fontana log in. I think she's having a little bit of trouble. So maybe somebody can send her a link to this.
I can send her a link.
I really appreciate it. Thanks so much. Okay. Okay, so let me, so this is Sofia Ionescu. She was born in Romania in 1920, and she was the faculty at Human Medicine at Bucharest between 1939 and 1945. And in the 5th year of medical school internship in the neurosurgical unit of the Central Hospital for Mental, Nervous, and Endocrine Disorders in Bucharest, she became interested in neurosurgery. And the first cranial neurosurgery was performed there as early as 1944. So because of this interest in neurosurgery, in 1954, she became a specialist in neurosurgery. So we basically credit her as being, at this point, the the first female neurosurgeon. And this decisive moment actually came to shape her entire future. So as she was unable to operate due to a wound, Professor Bagdazar, who was unable to operate due to a wound on one of his fingers, basically asked her to perform the surgery, saving the life of an 8-year-old comatose boy with an epidural hematoma. And so at that point, she was recognized for her skill as a surgeon and leading to his mentoring and support through the infancy of her career. So we really have a landmark, a person, but unfortunately, behind every woman, there's a man who has to support her and provide the impetus for getting a woman into the field. Our own Harvey Cushing, who was the father of modern neurosurgery in the United States, and perhaps everywhere in a sense, also was a strong supporter of a woman. Her name was Louise Eisenhardt. And this was a woman that actually came to be an assistant of his. And ultimately, he actually encouraged her to go to medical school, and she became a pathologist. And she became really one of the first neuropathologists as a specialist, and documented a lot of his cases. But she was not a neurosurgeon. And interestingly enough, she was the first president of what is now known as the American Association of Neurological Surgeons. But she actually was not a neurosurgeon per se, although she was a total friend of neurosurgery. She was a neuropathologist. And so it wasn't until 80 years later that we actually had a first female neurosurgeon of the AANS, who was in fact a neurosurgeon, Shelley Timmons, and that started the ball rolling for subsequent female president, who is currently in the AANS. Her name is Anne Stroing. So we're seeing, albeit slowly, a move towards accepting women in the highest ranks of organized neurosurgery. So over a career for Dr. Ionescu, over a career spanning 47 years, 25 as the head of cerebral tumors and 22 as the head of spinal pathology, she actually pioneered many technical advancements and contributed widely to academic research, was a mentor and an educator, and a wife and a mother of 2 children. Diane Beck, who lived from 1902 to 1956, was an English neurosurgeon, also at the time credited with being the first female neurosurgeon. Okay, so we have some parallel female neurosurgeons, and established a neurosurgery service in Middlesex in the United Kingdom. And during her 31-year career, she was the only female neurosurgeon in Western Europe and the United States. So now we have Dr. Jacoby, and she was the first woman in the United States who became a diplomat of the American Board of Neurological Surgery in 1961. Just a few years ago, we had her speaking at the Women in Neurosurgery meeting nationally about her experiences as a woman in neurosurgery. She's actually in advanced age at this point, but at least was able to give her some of her insights into being in her pioneering position. Also, Alexa Kennedy, a very important pioneer in our specialty. She was born in 1950 in Lansing, and she became the first woman and first African-American female to become a neurosurgeon in the United States. And she was in the University of Michigan. She did her residency in 1981, and she was the chief of neurosurgery at the Children's Hospital of Michigan in 1987, and she held her position until her retirement in 2001. She was a humanitarian and an extraordinary influence on many women, and of course, venerated by our women in neurosurgery. She said, "I was worried that because I was a Black woman, any practice opportunities would be limited. By being patient-centered, the practice growth was exponential." So she served her community, and she has served the whole specialty of neurosurgery by being so bold and creating a legacy of a humanitarian and pediatric neurosurgeon. So where are we today? So in 1965, females represented only 9% of medical school enrollees. And as we know now, not necessarily even 49%, but in many cases, it's up to 51% or more than half of medical school classes are women. And whereas when this slide was written, it was 15.8% of neurosurgical residents. Now it's approximately 20%, and now it's 8% of all board certified neurosurgeons. So things have actually improved since this slide was written a couple of years ago. But so we are seeing a lot of advancements. There is unfortunately some attrition in neurosurgery among women, which is 17% compared to 5% in male counterparts. And I think that could be multifactorial, and hopefully that we're not seeing, that those trends are reducing over time. So the question is, are we doing anything wrong as, in terms of women? And there are very few women right now in leadership positions, although now, fortunately, there is the AANS has taken the steps not only to have one, but in short order to have a second female neurosurgery president. So this is an excellent step in the right direction. And there are at least 2 or 3 members of the board of directors that are women at this point at the AANS. The CNS, the Congress of Neurological Surgeons, having lagged a bit behind the AANS at this point, now has had its first, his second officer for women to be an officer in the organization. That organization now is approximately 70 years old. And yours truly, was the first person to achieve an officer position in its 62 year history. So it took maybe a little less than a decade for another woman to reach the officer position at the Congress of Neurological Surgeons. The current leadership is extremely interested in making the Congress of Neurological Surgeons more diverse. And currently there are now many more women that are serving in the executive committee of the Congress. That's equivalent to the board of directors. And now we have one person who's the treasurer, Martina Stifler, and she, the secretary, and that position would be a stepping stone to the presidency. So we're hopefully looking forward to, in maybe 2 or 3 years, to see our first female president of the Congress of Neurological Surgeons. Things have been going a little bit slow in general, but now we're seeing more sections. The section of neurotrauma and critical care is now on its 3rd female chair. The tumor section is now, I think, on its first female chair, and the spine section as well. So we need more sections in the organization. The Senior Society, the Society of Neurological Surgeons, recently saw its first female president, which was Corinne Marasco. And so in organized neurosurgery, we're certainly getting there. And certainly I just joined the Society of Neurological Surgeons, and that organization has quite a few people, women now being raised in positions of that organization. So clearly there's a step towards diversifying in terms of gender in neurosurgery. But still, we have fewer women in leadership positions. We need more mentoring for women, and women need to see, just like anybody who is an underrepresented minority, of which women are in neurosurgery, as well as other groups such as African Americans are underrepresented in neurosurgery. We need to see more people who look like us in leadership positions in order to then allow us to understand that it's achievable. And the goal for this meeting today, for the brain turns, and for those of you women out there who are interested in neurosurgery but don't know that don't know whether or not you can, it is for you. Knowing that we have more women here in our group that we could, that we are now being more represented in academic centers, that it's important to see us and know that it's achievable. And we want to make sure and understand our goal is today is to let you know that it is achievable, that you don't have to sacrifice everything just to be a doctor. The Doctor's Blackwell, which was a recent book that came out about the first female, well, let's just say woman who graduated from I said a legitimate, let's just in quotations, medical school, because there were ultimately other female medical colleges that were not considered legitimate at the time, who actually was the only woman among men. And then her sister ultimately followed the same course. They were the first physicians in the United States. And it was generally felt that those women really needed to only concentrate on their careers, and therefore they didn't get married. But ultimately, what was interesting with Dr. Elizabeth Blackwell was that she ultimately had adopted a child, and so did her sister. So in a way, whereas she didn't have her own children biologically, she did want to have at least some sort of semblance of a family life. And so she pioneered women to enter medicine, but then also, but there was still that thought that we had to sacrifice everything else and only direct be married to the medical profession and not married to anybody else. So I think that this has changed significantly. And we really need to understand that we can have a life, we are entitled to a life, and we are also entitled to be neurosurgeons. The financial disparity mentioned here is that there's still not pay equity in neurosurgery, and we need to strive for equity across the board. We have important people that have become academic chairs. Dr. Marasco here is the first woman to become an academic chair of a academic neurosurgical department. I mean, there are women who are chiefs of neurosurgery departments in hospitals, but when we're talking about academic chairs, and this is where it's the importance or the perceived importance of being an academic chair, because then you're influencing generations of neurosurgeons to follow formally in terms of education. Dr. Marasco has the distinction of being the very first woman and it still holds that position in Ann Arbor, in Michigan. Dr. Liao was the second, and she became the chair at the Department of Neurosurgery in UCLA. And there have been subsequent women to follow. Lots of professors of neurosurgery. I want to point to Dr. Aviva Bosch, who is now the chair of neurosurgeon at a nascent program in Kansas, so in Omaha. And so she's developed a program. Dr. Timon has been the chair at Indiana. Dr. Julie Politzis, who's not listed here, has become the dean at Florida University, I think, in Florida. And so now we are getting to see more women advancing into these positions and becoming chairs and professors, and certainly influencing generations. Odette Harris has been the distinctive professor at Stanford and with VA and the Department of Defense. So lots of wonderful women here, and Judy Wong. So we have a tremendous number of women that are up and coming that we need to laud as well. Again, as I told you, this was at this time of the writing of this particular talk, there was only one female president of the AANS. But now, as I have spoken to you, we're increasing. A shout out to our very own Ronique Gilad, who is now not the interim chief, but in fact the chief of neurosurgery at Staten Island University Hospital. She's extraordinary. I've known her for many years since she was a resident in Mount Sinai. And she has been extraordinarily accomplished clinically and operating a very busy neurosurgery service over at Staten Island University Hospital. I'm proud to call her my colleague. They have a slide on me. Thank you very much. I am the director of neurotrauma, so this is, I guess, a formal introduction of myself. But yes, I was a former vice president of the CNS and a former president of WINS and a past chair of the section on neurotrauma and critical care. Shelley Timmons had the distinction of being the first chair of our neurotrauma section, and I came approximately I was about 1 or 2 years after her. So it was, it's great. We now have Patricia Rathson, who is our new chair, and with other women like Martina Stifler coming up the line. So the trauma section is really head. Here we have, Soraya Motovala, who also was a resident at Mount Sinai, who I have the distinction of knowing for many years. And they're the two powerhouse women at Staten Island, and certainly making a huge difference in the care at Staten Island in terms of neurosurgery. They're full-time academic neurosurgeons. And it's important to have these mentors and have the face of these wonderful women when you're entering into programs. I think most neurosurgical programs throughout the entire country have at least one female faculty. I think it's only down to maybe 1 or 2 that still do not have women as faculty members. So we need women, and we need more women. We need to understand that women are equally capable of doing this job, and that's a given. Now it's a matter of just being more proactive in recruiting the best and the brightest, including the women who are the best and the brightest in our specialty. So addressing some of the workplace flexibility, lack of affordable and available childcare, these could be problems, especially when it comes to women in medicine, and especially in the surgical subspecialties. So most women neurosurgeons feel that it would have been impossible historically to have children in residency, although a lot have had them, or some have actually. I do know one neurosurgeon out west who actually has 9 children. And she is a great neurosurgeon and juggling a very large family. Certainly, while that she may necessarily be an outlier as a specialist, what I would say is that it certainly speaks to the possibility of having an active family. But it's important to know that work-life balance is especially challenging for women, because women have some sort of innate need to be more involved maternally with their children. And so a lot of some of that activity does fall upon women, and we are still thinking of those things. So there are challenges, and it's never easy. What's important is that we need to have a support around us in order to make this happen. And so in the workplace, it would be great if there was more attention to maternity leave. 80-hour work week requirements for graduation are important, but there also has to be some allowances. And also, as we graduate from our residencies and we want to become board certified, the ABNS has asked about trying to see how we can write into our regulations for when you become board certified and what the rules are to account for women who take time off to have families. And that also is a very important thing. In women in medicine, on average, incur 20 more hours a week of parenting than their male counterparts. And this is across the board. I don't know how much to change that other to sort of accommodate around that. Unfortunately, with neurosurgery, it really is not a specialty that's amenable to part-time work unless you find a unique niche way of doing that. And so when we're choosing to become neurosurgery, we really do need to understand that. Female neurosurgeons are paid about $90,000 less per year on average. There is a pay gap that we need to try to narrow that gap in order to achieve equity. So I think that attitudes towards women are certainly changing. More men are used to having women as their medical school counterparts. Women are now taking the steps to seek their mentors, to seek research opportunities, to seek shadowing opportunities in order to understand whether neurosurgery is right for you. But discrimination can take many forms. There's microaggressions where there's little comments that could be made that are maybe implicitly or not intentionally discriminatory, but can have that overtone of being discriminatory. Women can still be being passed over for jobs or positions if there's a competing male for the same role. And these certainly the implicit biases. There's also imposter syndrome that seems to be maybe more a higher predilection for women because you feel like you didn't really quite deserve where you are, and people don't really know how unqualified one really is. This is a perception that women have, and I think that we have to try to work against that. Women are more likely to point out their own flaws and underrate themselves, and are not as good in self-promotion as men are. Men are much better at self-promotion. And I think in order for us to sort of change this attitude and this tendency towards this imposter syndrome, we really have to work on our own attitudes to say that it's okay for us to self-promote. It's okay for us to feel confident. And I think that the more we can allow ourselves to do that and not sort of cave into what we perceive the cultural norms are, that's how we push through those cultural barriers and then change attitudes. So in this study, it feels that, female physicians actually can have better outcomes than male, maybe because they're really trying to pay attention towards the patient care and being more patient-centered. And I think that should be across the board. Male and female should be patient-centric. And in that way, we can then try to improve the outcomes across the board, and not just have even a differential, which is interesting that female physicians might have overall better outcomes compared to their males. So thank you, Dr. Motivala, for this putting together this talk. We have a half hour left. I just want to leave it open to a lot of questions, and our moderator to sort of just help guide us through any of the questions that you might have. I'm gonna stop sharing this screen. Oh, Dr. Motivala, you're online.
Yes, the link wasn't working. It was quite a bit of a challenge. Hi, everybody. Great talk, Dr. Allman. What's really gratifying is I prepared this talk a number of years ago, and I've given it in different forms over the years. Every time I give it, the sort of status in women in neurosurgery gets better and better. Every time I give it, there's an edit. There was only one of us, now there's two. There was only three of us, now there's five. It's incredibly gratifying. I feel the rate of change has increased dramatically. I think it was very stagnant for a very long time. I think when Dr. Allman trained, it was exceptionally harder to be a respected woman neurosurgeon, and women like her had to do an incredible amount of legwork, and deal with an incredible amount, in some cases, of abuse to get to where they are. And then for me, I had Dr. Allman as a mentor, and then I had my partner Ronit as a mentor. And so each successive generation is finding it a little bit easier, a little bit more exciting, and that's really gratifying. I think to your point, women neurosurgeons now train male neurosurgeons, and that's so important. It's important for us to be mentors for women. Absolutely. It's also equally as important for us female attendings in academic neurosurgery to be mentors to men, because it becomes a norm where your now male colleagues, especially the younger generation of male colleagues, are absolutely normalized to work with women. They don't look at you as a woman who is also a neurosurgeon. They look at you as their neurosurgery colleague. And that's such a great distinction. And I see such a difference and such a change, to the point where Ronit and I, our new junior partner, is a gentleman who was also our resident, and he actively sought to work with us. He had other job opportunities. We didn't have a job for him in Staten Island, and he called up Ronit and said, "No, I want to work for you." And this is very exciting to me, very exciting.
So I know, Elizabeth, you've also joined us. That's Dr. Fontana. I just want to give you the opportunity to introduce yourself and make any comments about women in neurosurgery from your perspective.
Oh, that's very broad, Jamie.
Yeah.
But I mean, I would echo
Elizabeth, I think your connection is a little bit
scary, that it does feel moved or has sped up a lot. Bad? Yes, no?
a little bit better.
Can you hear me?
Yeah, we hear you. It's a little sketchy, a little chopped.
It's breaking up in and out. Sorry.
You're
I don't
good
know.
now. You're good now.
Okay, I just won't move. Yeah, I was just gonna say, I agree that the rate of change has sped up. I think there's like maybe many factors contributing to that. I feel like part of that has been the increase in number of women in residency, which partly is, if I'm not mistaken, that the RRC is now sort of like taking a more active role in making sure that programs take women and diversify the residency programs. And so, obviously just having more women in the pipeline makes a tremendous difference in the whole thing. So, yeah.
Yeah, well, so Dr. Fontana is a neurosurgeon that joined the Northwell group quite a few years ago, was chief at neurosurgery at NUMIC and full-time faculty member at Northwell, and now the chief of neurosurgery at Jamaica Hospital in Queens. So
yeah.
Anything about I don't want to take the moderator position away. I really
No.
but while I'm talking, anything about your training and now that you've brought forth and your experiences during training as a woman in neurosurgery and how that's impacting your practice now?
Sure. Yeah, I mean, so for the vast majority of my residency, I was the only woman in the program. There was 1 year that there was another woman. So it was, a pretty isolating experience from my standpoint. And I think that's not uncommon. I mean, there's definitely residency programs now with multiple women, but there are still ones with only one. There were no women on the faculty. So, there was really nobody to look to. And there was also like kind of no way to fly under the radar because I looked different and I thought differently and I didn't quite fit the mold. So, it poses a challenge, which I think can come in lots of forms. You can be, a minority of any flavor, but it's not awesome. And I think that perspective, I just just think like the solution is just numbers. It's just a simple answer. That like if you have more of whomever, then you become less of an anomaly, and also the experience just becomes less painful and lonely. And so yeah, I'm trying to think what other.
We have quite a few questions coming
Yeah.
in. I might just quickly reintroduce myself for whoever missed it at the start. So my name is Anuradha. I'm a second year medical student from Australia. And on behalf of everyone else and everyone who sent in messages saying it was a great talk, it was really inspiring, and it's really great to hear such great things from very accomplished women. We have quite a few questions coming in on the topic of dealing with sexism in the workplace, both from colleagues and also from patients. And firstly, how do you deal with that psychologically? And secondly, when do you know when a good time to speak up about these things is, and when do you just keep it in and be thick-skinned and let it pass?
Those are tough ones. And I'm looking at Dr. Allman, I'm looking at Dr. Fontana. I'd love to say that I have a magical answer for this. I would love to say that it doesn't happen anymore, but it does. We all know it does. I think, unfortunately, just from the time period, I know for all of us that we have come up in this profession, you do develop a bit of a thick skin. You do let a lot of things, sort of roll off you. Whether that's right or wrong, I don't know. I think, it's it's a tough thing. I think if I felt like it was more than just passing comments and something that was a little more intrusive and aggressive, I would say something at this point. I think you can say something at this point. I think in the past you could not. It would have blown back on you. I do think that administration is largely intolerant of these kind of behaviors. I think, though, I am so used to just ignoring it, I don't notice a lot of the time anymore. If I sat back and looked in a day, I'd probably notice it more. And it is tough. I'm not going to sit here and sugarcoat that it is tough. Yes. When patients say things, if I'm uncomfortable for my safety, I would say something. Otherwise, I ignore it. With my younger male colleagues now, sort of, I remind them that they cannot say stuff like that. And I remind them more for the sake of their interactions with other people, because it's just not acceptable. And it's just, but sometimes I'm at conferences with very, very old male neurosurgeons, and, they're kind and they're nice, and they just, to this day, don't understand that what they're saying is unacceptable. And I sort of just laugh it off and ignore it. And, it's, I don't know if that's right or wrong, I'll be honest. But again, it comes from decades of just having a really thick skin about these things.
Well,
Yeah.
Go on,
Jamie.
Go on. No, go on.
No, I was just going to iterate, like, it's, I feel like there's kind of like two categories. There's like harassment, and then there's things that impact your practice. And so, if it's something that, like all the things that Dr. Allman was pointing out, like, pay gap, for example, or maternity leave, or those kinds of things, then it's sort of, I think that then there's a reason to, point out a discrepancy if there is one. And I think that's when it becomes extremely important. I don't know the answer. I agree with Dr. Munavala about sort of the day-to-day. There is, neurosurgery is such a small community. And I think all of us also share the anxiety to some extent that if you make a comment about something, you don't want to be that person either. That's, kind of like the one who complains. So, it's very tricky. It's very hard. Again, I think it just comes down to there being more women and normalizing the whole experience.
Exactly. I mean, you don't see this. Like, I grew up, I went to medical school in a class where women, I think, were constituted maybe 30% of the class. It was a fair I mean, there was just a lot of women, a lot, I think it was actually almost 40%. And so it was, men and women are together, we're treating each other as colleagues and we're getting along, and it's that kind of interaction from early on that they begin to understand this, we shouldn't be sexist or discriminatory, but it really disturbs me when someone writes and says that you're shadowing under a male doctor and you're getting blatant comments that are racist or sexist, and that's very disturbing. First of all, I wouldn't shadow those people. That's injurious to your plans and desires to learn about medicine, and all you're getting is just a perspective that's completely wrong. We need to change that. You need to find an opportunity where you could shadow a doctor of repute. If it's great, but just let's find somebody who's going to treat you with respect and be neutral. At the very least, just be neutral and show you what your goal there is, just to become a doctor. And you don't have to be encountering that. And I just hope that when you reach medical school, that you're certainly not going to be encountering that in medical school, because you're going to be in the majority in medical school by the time you enter there. So it's just unfathomable to me in this day and age that you can encounter that, but I guess you can. Especially
and this, I think, brings it back to the fact that I think women now have more choices. And if you go to interview at a medical school, if you're shadowing with a physician that makes you uncomfortable, if you are interviewing for your neurosurgical residency and you are getting the feeling like this is going to be an abusive place, the answer is you don't have to go there, because other people will want you. And that truly is where we are with choice. Okay. There is a understanding and a push that programs are better when they're inclusive. So across the board, you don't have programs like the John Jane programs of old where they said, I will never take a female resident. That is not happening anymore. And that, I think, is one of the greatest gifts that women like Dr. Allman, Dr. Germano, Dr. Abash, all of these ladies who fought the fight got us to this point where we have options. Okay. And that's really huge for me. The other thing is, people are entitled to their opinions and you do not have to listen to them or take them to heart. Okay. This idea that, I saw lots of comments and it broke my heart about, people saying, how are you going to be a good mother if you become a surgeon or go into a demanding specialty? Okay. And the reality is you will be a good mother because you will want to be a good mother, and you will be a good surgeon because you want to be a good surgeon. It doesn't mean it's going to be easy. It doesn't mean that there aren't going to be times where you are so overwhelmed, you're wondering how you are going to get through the day, because we've all been there. Okay. But certainly, I never question. I don't listen to those things anymore. Oh, how are you? You're never around. My kids are wonderful. They're great. They're smart people. I'm very proud of them. I get help. I accept help. I understand that I'm not going to be everything to everybody. But, I certainly would never, ever care what some random male doctor has to say about my parenting skills when he probably hasn't seen his kids in 7 days either. So you just have to ignore these things. And that is unfortunately true. And you have to believe in yourself, and you have to believe in what you can accomplish, and, set your goals and go for them. That's it. That's what you can do. And no, you're not going to be, everybody to every person and everything you want to be. And, sometimes you're going to miss signing your kid up for chess class and they're not going to get a spot. And you know what? They're going to be fine human beings. And it doesn't mean you're a terrible mother. And that's just what it comes down to.
Well, I think it's just, there's an interesting comment that just came up, like discretion to speak up is hard and staying silent is best because it affects your clerkship grade. However, it's really unhealthy to bottle everything up and not stand up for yourself. Unfortunately, you learn to grow a thick skin and get desensitized. So as a medical student, you have the power of making comments on your evaluations, okay? And you can say, Dr. So-and-so by name commented negatively about my being a bad mother or something like that, or made disparaging comments. But there's also something called an ombudsman. If you have a question or a concern about discriminatory behavior or abusive behavior, you can go to those people. It's supposed to be confidential, and they're supposed to bring it up to the higher authorities. It is not acceptable in today's LCME medical schools or anywhere for someone to be harassing or to make disparaging comments or to discriminate. And there are ways to bring that to somebody's attention. The growing of the thick skin that Dr. Modavala is talking about is that you got to know when it's threatening and when it's not threatening. You know, things that are threatening have to be addressed, but I'm going to confess it's not that easy. There's concern for retaliation. There is all of that. And we still don't feel very comfortable, even if we have those methods by which we can complain anonymously. You know, if you're the only woman in the program and somebody makes a complaint, they're going to try to figure out who it is. So it's not that easy. But when we say desensitize, it means that, you know, some guy says something offhanded. If they're not really, you know, making good on that, or just like being stupid, you learn how to deal with it. You know, you're not going to call out everything, because then that's just like, it's not necessary to do that. So you got to learn to distinguish what you feel that is injurious versus just sort of dumb.
I definitely think it's really comforting for us to hear that as early career students or physicians, everyone tuning in, to know that we're at a day and age where it's acceptable to speak up when we're mistreated or when our value isn't taken seriously. We have a couple of questions about, you know, the pay difference between males and females. So why exactly are females paid lower, and what are some things that we can do to actively try to change that or advocate for ourselves?
Well, I think step one is advocating for yourself. I think traditionally, historically, women are not as aggressive when it comes to contract negotiation. We haven't historically. There's a certain amount of just being grateful that they gave you a contract, you know, kind of a thing, that I think is longstanding. I think that also goes back to when we talk about imposter syndrome, right? Women tend to, you know, have a little more maybe insight into their flaws, concerned about their flaws, and then maybe don't feel they deserve as much as they do. And I think that affects sort of not just your academic promotion, but your financial promotion as well. And that all goes into it. It's also what, as it turns out, may make us better and safer doctors, as the Harvard study showed, because self-reflection is really important to improve on patient care, to get better at your job. So, you know, it's kind of a double-edged sword. It's both like a blessing and a curse. So I think one of the most important things for young people when you're taking that first job, that first contract, is talk to people, talk to other colleagues, friends, mentors. We get quiet when we are talking about compensation. It's like we don't want anyone to know what everybody else is making. You know, when you are going out and getting your first job, if you have a colleague from your program who is looking for a similar job, you know, that's a great person to be like, what did they offer you here? What are you looking at here? And, you know, a GI friend of mine in her very first job, same fellowship, same job, she got offered about $50,000 less than her male colleague right off the bat. But they talked to each other, so she knew. So she was able to say, this is not a place I want to go to, that you would do that. And so, you know, you can be more aggressive than you think you can, and stand up for yourself. You deserve to be fairly compensated.
Elizabeth, any thoughts in that realm?
Yeah, I mean, I just went through the process before I came over to Jamaica, and I mean, you just have to advocate for yourself. I had one interview, which shall remain at a very prestigious academic center, and that will remain nameless. But I sat down at the very end of the whole 3-day process, and the chairman sat down, and he said to me, "Well, so you have 3 kids?" I have 3 kids. And I said, "Yeah." And he said, "Well, so how are you managing your life?" And I said, "You mean my job?" And he said, yeah, your job." And I said, "Well, I have somebody to help me when I take call, and because I'm a single mom." And he said, "Well, how would you feel about a not full-time FT position?" And I said, "Well, so then is this not a production model?" Because I thought the job was a production model, which means you get paid based on how many surgeries you do, how many RVUs you do, not based on an FT, which would be a salaried position. And he said, no, it is a production model. And I said, "So you're just asking me if I would like to come in at a lower base salary? Is that what I'm understanding? You want to know if I'd like to do the same job for less?" And he said, well, no, the expectations would also be lower. And I said, "Well, so let me clarify this, sir. You want to know if I would like to come in to the same job everyone else has for less money with lowered expectations?" And he said, well, we don't have to talk about this anymore." And I said, "Yeah, no, I'm only interested in the full-time position." So, that kind of thing happens. And it was entirely, it happens. So.
Wow.
I
Real life
No comment
example
beyond that.
of
you know,
this
you
baby.
really, sometimes I have been asked to take extra call. I said, not at my current job, another job. And I'm very happy at my current job, Dr. Shuba, if you're listening. But I was asked to take extra call, and the other men in our practice, would take extra call, and they would get paid extra for doing extra. There's the expectation and then more, and they would get compensated. I said, sure, I'll take the extra compensation. I have small children. I can use the extra money. Sure, I'm happy to help. I actually got a call from another male surgeon who said, when I was your age, I would have taken this extra call just for the experience. And I said, oh, and I felt guilty for a second. I almost said, oh, okay, sir, I'll do it. And then I sat there and I thought, so what about all my other colleagues at my same level and age who are getting all this extra call pay? Don't they need that same experience? And I stood up for myself. And I remember feeling sick. I said, no, I'll do it. Happy to help. I want to be fairly compensated. That was it. Got off the phone and I felt sick to my stomach, like I had done something wrong. It took me like 3 days to wrap my head around that all I was asking for was same, not more, but same. It's been a lot of reflection as to why I would feel guilty about that, about just wanting equal. And then I promised myself I would never, ever, ever feel bad about that again. And that is really part of the growth process of just, you just stand up for yourself. That's it. And no one's going to do it for you. If you're lucky, you end up with a mentor and a support system that will help you with this, but you cannot depend on it. You have to be your own best advocate. And I think that goes for anybody in this career. I think that goes for some of my male colleagues at contract time. Everybody's got a different personality, and some people are braver than others. The answer is you just, you have to, you are brave, right? Any woman who wants to go into medicine and have a family and have a career, you are brave at baseline. And you just have to trust that will carry you. And it will. And I feel like it took me a long time to get to that point. I think I see younger women reaching that point earlier, and that makes me feel very good about where we're headed.
Do we have time for one more question?
Well, I think we have a couple of minutes. I have a meeting at 11. But
Hey guys, I'm going to chime in. Thank you so much for doing this. And it's always greatly appreciated. And I think, you know, I gave this talk when Brain Turns first started, but I don't know if you guys know the context or not, but when we started Brain Turns now in 2020, I guess, or 2019, you know, we had all these registrants. We were pretty amazed, and we had 16,000 registrants the first year. The second year, 16,000, right? And it turned out like 60% of them were new. Okay. But when we looked at the people, the demographics of who was enrolling, about 83% consistent over both years were female, were women. And so this is, you know, just, it's such a critical component to this whole experience is to have this lecture and have your guys' advice, because I think it really is powerful for the people watching. And, you know, they come here for medical knowledge, but they come here also to understand what life is going to be like for them and how to get to be where they want to be. And you guys are all success stories. And so it's just so important. And I can't thank you enough for being a part of it and taking time out of your day.
thank you, Randy. Thank you so much. I think it's been great. I'm sorry we couldn't get to all of you guys' questions. It's just a vast topic, and we can, you know, spend hours talking these things. So
We'll have you back. We'll have you back next time. And thank you guys so much again.
Thank you so much.
Thanks, Dr. Allman. Thank you for giving such a wonderful talk.
And thank you for providing the slides. All right, take care.
Have a great day, everyone. Thank you.